Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today. We're excited to bring you another in our series of interviews with top leaders in health IT. Today we're here at the HFMA annual conference. We have two guests. We have Dr. Brittany Cunningham. She's vice president for the episode of Care Office Population Health at Vanderbilt University Medical Center. And we have CJ Stimson, MD. He's chief medical officer of Employee Health Plan at Vanderbilt University Medical Center. Welcome.
Thanks for having us.
Yeah, excited for the discussion. I know you have a presentation here at HFMA that you're sharing some interesting insights, but before we dive in there, CJ, why don't you start off, tell us a little bit about yourself and VUMC.
Sure, happy to. So I'm a cancer surgeon at Vanderbilt, practicing cancer surgeon, and have a chief medical officer role with our health plan, as well as a senior vice president role in population health. Brittany and I have both been at Vanderbilt for some time. She'll tell you how long she's been there, but Vanderbilt is a large tertiary quaternary academic hospital. So we have about 3,000 doctors, 5 hospitals, about $7 billion a year in revenue, and we've been around taking care of Tennesseans for about 150 years.
Wow.
Yeah,
awesome.
So we've been here for a while. We're going to stay for a while.
That's awesome. Well, you take care of my sister, so thank you.
Perfect.
Brittany, how about yourself?
Well, thanks for having us. I am Brittany Cunningham. I'm a nurse by training. I've been at Vanderbilt for 21 years now, and used to be a cardiology nurse, and now have gone more the healthcare administration route, and have started this bundles program that we're going to be talking about today in 2015. So thanks for having us.
Awesome. Well, and I love having kind of the provider and the payer side. This is going to be a really fascinating discussion. Maybe Brittany, you could kick us off. What is the difference between a provider-led versus like a payer-led bundle?
Yeah, so we have called our program a provider-led program because we are clinicians. You have heard CJ is a surgeon. I am a nurse. And we are providers. Vanderbilt University Medical Center is known for the clinical care that we give, and we started this program by focusing on the patient and the clinical care that we give first. So there are payer programs out there that start with the payer model, and then we'll give it to providers, and then providers have to form the clinical care around that payer model. And ours is the opposite. We start with the clinical care first, and then we put a payment model around it.
It's interesting. That makes so much sense. Like, why didn't we do this before? CJ, what would you add?
Well, what I would add is I think that all the stakeholders are trying to approach value-based care in whatever way they know and whatever is in their DNA.
Right.
And for us, like Brittany said, we're providers at heart. And so we're coming at value-based care from a provider-centric approach, and payers are coming at it from a payer-centric approach. And we each have different strengths and weaknesses, and I think those are on display in the value-based care arrangements that we put together. And as Brittany highlighted, I mean, for us, like, no one is more front and center with the patient than we are. And so I think that is what you see in our value-based arrangements, particularly our bundle payment program. Is that we really put the patient at the top, and how we can support providers in maximizing the outcomes for those patients.
Interesting. So you talk about some of the strengths, what are some of the benefits of these provider-led bundles?
So what we think is some of the strengths of our provider-led bundle payments is that they really focus on how we get that best outcome for the patient, and we put ourselves at risk for that. I think the challenge and the conventional wisdom in value-based care is that providers aren't that interested in taking on risk. They don't want to move into value-based arrangements because they're afraid of the loss of value that could occur if they're not made in a way that is amenable to them. And by leading the way in these arrangements, we have built value-based programs that are really focused on how we take care of patients and how we can deliver the best care for those patients. I think payers, they're just not that close to the patient, and so they can't build arrangements that providers won't be interested in, and they don't have the bona fides, if you will, to appeal to the providers because the providers need to know, I'm going to perform well in this. Like, I can perform well in this. And I think that's what Brittany and I do, is that by creating provider-led programs, we are creating programs that liberate, if you will, providers in a way that allows them to do the best they can for their patients and for their patients to have the best outcomes. I think it's just difficult for payers to do that. I spent time at one of the largest payers in this country, Medicare, and we only had so many tools at our disposal to reach the patient. But for Brittany and I as providers, we have so many more tools to help patients get to the best outcomes they can. And I think we're really fortunate to be able to do that.
So talk to me then, Brittany, about how did you discover what bundles work, right? Like what was the process of discovering it, so that you know that, hey, this is an effective bundle that providers will want, to your point,
Yeah.
right? That will make sense to the providers. What was the process? Is it about data? Or, what was the process to discover these bundles?
I think there's a lot that goes into it. I think talking to your stakeholders is a great place to start. So talking to the providers and understanding what they are willing to take on risk for. Talking to our customers who are interested in where their pain points are, what are their highest cost areas, and what are their needs for solving a value-based care arrangement for. So I think those are two key areas that we started with when we were interested in starting to develop this program. We talked to our internal stakeholders, our external stakeholders, and the data. And we looked at a lot of data to see where high cost areas were. Yeah, I think those are three, great places to start.
I think what I would add to that is that value is really it's just a tool that we use to get the healthcare system to perform better. And so what Brittany and I are constantly focused on is, where is the system failing to perform well? And how do you get at that question? And what Brittany was highlighting is that there are lots of perspectives on where the system is not performing well. And it can't just be what we think as the provider. It can't just be what the payer thinks is the problem. It can't just be the patient. It's all of those elements, all of those perspectives have to be taken into account. And I think that's what we've tried really hard to do, is to bring in those perspectives. And I think because we've built our program around that, we've had a lot of success, because the areas of opportunity that we've identified, they're real. They're real because the end users have told us that they're real. And it gives us a lot of confidence that our program is going to make a meaningful impact for patients.
What are some areas where you found that these work really well? I'd love to hear some examples of what does a bundle look like and how does that impact patient care? And maybe are there some areas that you thought maybe would be good and it doesn't work, or you haven't got there yet, right, to figure out what the right bundle is? Any examples?
Sure. So we started with maternity, which was not where we thought we would start. We thought we would start with musculoskeletal. That's kind of the typical when people think about bundle payments.
Okay.
So talking to our external stakeholders, talking to our customers, they actually guided us to maternity and said, this is our biggest pain point. This is where our high cost needs are. So we pivoted and we created a maternity bundle first. And what that looks like is everything from the first prenatal appointment to 3 months after the delivery. And so everything related for the mother, your ultrasound appointments, ED visits, your delivery, vaginal or C-section, it doesn't matter. So really very comprehensive, very holistic for the maternity care. So that's been our longest running bundle. We also have the musculoskeletal, we have spine, hip and knee surgery, we have osteoarthritis, shoulder pain.
Wow.
So we've really gone expansive in that area. We have cochlear implants, which is a little bit different than what you would expect.
Yeah, I wouldn't have put that on the list.
And I don't want to say that's not one that is not a way to go, but I think it's a little bit harder to get market to come to it, because We do direct contracting to employers, and any employer just does not have a lot of volume for that. So that's just a little niche area that we have because we do the highest volume of cochlear implants at Vanderbilt. So those are some examples. A couple of others. We have surgical weight loss, medical weight loss, kidney stones. What am I forgetting?
Substance use disorder.
Substance use disorder.
Oh, interesting.
So we have quite a few on the list now in the suite of bundles.
Yeah, it's amazing how it's grown. What were some of the administrative or maybe even technical challenges you had to overcome to make this work? CJ, maybe you could start?
There are none.
It's healthcare. It's easy,
yeah,
right?
It was just like that.
You just decide this is what you want to do, and then it happens. That's it.
17 stakeholder meetings,
Yeah,
and committees.
yeah. I don't know, maybe like completely transforming the entire revenue cycle of the hospital. Like that's a good place to start. I mean, what Brittany and I know is we know the clinical enterprise, right? We know the clinical care, and there was a lot of work that need to happen around that. Workflow changes, recognizing where the opportunities are, redirecting patients. But what we didn't know very well, I think she would agree, is all the back of the house effort that's required to make all that clinical work run well. And all of that has to be reinvented as well. And so we've had to learn a tremendous amount about finances, accounting, revenue cycle, benefit design. All of that has to be tailored to value as well.
Yeah.
And I think that was a learning for me. I won't speak for Brittany, but for me, that was a big learning.
I don't want to embarrass myself in front of the HFMA audience on how naive some of our knowledge was.
But we've done a tremendous amount of learning, and we've found the right partners, and I think we're solving for those really hard problems, which are on that kind of back of the house rev cycle administrative aspect. They are solvable. They're just challenging to work through.
Yeah. Well, I think the best outcomes in healthcare come when we do the clinical and the financial and the IT. You know,
Yeah.
like when they all come together to solve a problem, because you can't just solve it in your silo. I think
That's right.
That's what it sounds like.
I think that's a really good point. Even just the IT part of identifying the patient so that the claims can be routed differently was that was huge.
That's an epic journey.
Oh gosh, it was a big ordeal, but that was very important to be done, and it played a big role in reinventing this whole journey.
What an opportunity for technology, though, like, because we could do that, right? So that's awesome. Did you decide what conditions kind of make a good bundle that some other people could use to learn from you? Is it the clinical side needs it? Is it a certain reimbursement framework, or was there any sort of, conditions that you're like, oh, these ones made sense? I know you said you talked to the stakeholders to hear from them. What do you want to do? Were there specific things that made sense?
I mean, go to your stakeholders, ask them where their pain points are. There's some elements that are common. It's helpful in this type of value-based arrangement, a bundle specifically, to have a start and a stop to the experience. We kind of grew out of the office of the episodes of care. That's a very common description of the type of healthcare experience that is amenable to a bundle. And so you're looking for things that are episodic in nature. In order for you to be successful in kind of squeezing the most value out of whatever episode that is, it's helpful for there to be large volume. It's about muscle memory, repetition.
Okay.
That way it can be meaningful for whoever your customer is, if that's a payer or if it's a purchaser. And also your clinical enterprise can get that muscle memory to do things differently for
To
that
improve.
to improve if you're doing things for that population.
Wow.
Yeah.
That's interesting. Yeah, I noticed there's no cancer bundle, right? Which is an episodic usually, unfortunately.
Not yet.
Not yet. But it's that brings up another great point, which is in order for these value-based care arrangements to work, bundle payments to work, you've got to be able to transfer risk from the person who's purchasing the care to the person providing the care. And that risk has got to be manageable. And so that's another element of the episode is what is the variability like inside that episode? What's the distribution of utilization? Sure. And if it's not something that can be managed in a risk-based arrangement, like it's going to be hard to move that into value. That's what we were talking about with cancer is a lot of folks have tried to do cancer in a value-based way, but in order to manage that that utilization, that variability, they've had to really narrow the population, right? So it's only an episode of chemotherapy, for example, right? Sure. And that's good for value, but that might not solve all the patient's problems because not every cancer patient needs chemotherapy, right?
Sure. Or Medicare has done radiation.
Exactly, and so there is such thing as a clinical experience that's probably not really amenable to an episodic bundle-based arrangement. And you need to be careful about what you bite off when you're building them.
Makes sense. Any final thoughts, Brittany, about this or insights for other organizations that may be dealing with these same challenges?
I think, we're of the mindset just start somewhere. So even if, CJ mentioned the volume builds muscle memory, but even just doing a small value-based arrangement is making a difference. And so
it builds muscle understanding of what works and what doesn't, I guess.
And lessons learned. And so anything that you can do, any institution can do, is starts moving this curve to value-based care, which is what we're passionate about. And so that's if we can help in that arena, that's we are willing and able to help.
That's awesome. Well, I appreciate you helping here by sharing this approach that I think a lot of organizations can use. So thanks, Brittany.
Thank you. Thanks for having us.
And thanks everyone for watching and listening.
Appreciate it.
If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting application. Thanks, guys.
Hey, thank you.